Hello, welcome to this presentation. I had the privilege of attending the SPIN 2021, sharing the progress in Neonatology 2021 that was held recently within June 10 to the 12th. It was completely online virtual conference. I had the privilege of meeting top neonatologists from the world and the updates from horse's mouth. Correct? They are the one who set the trends in neonatology, and as told by them, as presented by the stalwarts in neonatology, I am reiterating the salient points. I'm not going to complexities of the talks, which I understand, but to simplify that and to emphasize on the essential, crucial points, I'm making this short presentation on each of those topics. To start with, the first topic will be use of oxygen during the first 10 minutes of life. Life of a baby starts at birth, and this we call a resuscitation, that is to facilitate transition from the in vitro environment to the extrauterine life. 90% of babies don't need any resuscitation, and 10% of them will require, and 1% of them will require to the full extent. Is to recollect the basics. Right now, Professor Ola Saugstad, a reputed figure in neonatology, oxygen-free radical concept in neonatology, is the father of free radical disease in neonatology. Means the inventor or discoverer of free radical medicine. As he rightly pointed out, the things don't change that easily. To bring out change requires strong commitment and a drive to achieve dependable or results which can be believed by the majority in the world. To achieve this change from 100% oxygen to room air, which is a transition that lasted, he says it takes 2 centuries, 200 years, oxygen was thought to be used very liberally. Go there, very liberally, I'd say. Go next slide. He is Ola Saugstad, Professor of Pediatrics at the University of Oslo, Director of the Department of Pediatric Research at the National Hospital. He is a world-renowned expert in neonatal medicine. I have had the privilege of interacting with this man when he was in his early 40s. That was when he was doing DM neonatology in Chandigarh. At that time, we had invited him to PJ Chandigarh, and he was grateful enough to have honored our department by visiting us, and we had a fabulous talk by him. I remember one question at that time, the starting fluid in Stockholm was 5% dextrose, whereas we all were using 10% dextrose. He explained things vary between the units, and the logic of it will be understood by the in charge person of that unit. In one word, he put that very politely. I remember this polite man those times, but a committed researcher, free radical disease. Other question I posed was, we understand why this free radical disease can be behind this ROP and as well as BPD. He was carrying his ideas much forward. He said NEC is a free radical disease. Necrotic enterocolitis is a free radical disease which at that time was not reaching the minds of young neonatologists like us in training. Right. So now how this change came. See, you can see this time frame, look at this very carefully. Oxygen does no harm to newborn infants at birth. Use here only if 100% oxygen is unavailable, means there were deliveries which are happening in the community, domiciliary deliveries. Almost 80% of deliveries in India were delivered at home. This is statistics as of 19 80, even to the late 1980s, 80% of babies in India were born at home. Village boys were playing a major role. However, they get 100% oxygen. So this was basically meant for resuscitation means oxygen. Oxygen is available in the hospital. So like that, the concept was there. But 80% of the babies everywhere were delivered at home or in villages or might be on the fields also. Okay, at that time tetanus was a major killer because even to cut the cord, a sterile cutting equipment was not available those days. So from that 18th century to 2000, a full 200 years, oxygen was a miracle drug available in the hospital, and more the babies are delivered in the hospital, the better outcome will be. Good, in 10% of cases it is reality. But then at the time, as the neonatology advanced, we managed to save more preterm babies, more of babies of lesser weight. Then came the complexities of the neonatal care, especially retinopathy of prematurity, which became a major villain, blinding illness of preterms. It was attributed to oxygen in landmark studies, and from that time, research was focused on oxygen-free radicals, and no one was taking it so seriously as Saugstad, who said the risk of oxygen-free radical toxicity is more the earlier the life. Means he said you should start resuscitation with the air or little bit of oxygen, not 100% oxygen. This was a revolutionary thinking of those ages. And to prove that and make people believe that idea, he had done a rigorous multicentric trial involving many researchers, including India. And after those publications, the ILCOR, see this ILCOR, International Committee on Resuscitation. So this is the one which will decide how we resuscitate, set the standards for resuscitation for a newborn. Every 5 years, the standards are updated. So up to 2005, there was not even a recommendation to check the saturation of the babies. It was all the clinical assessment of the person doing resuscitation. Cyanosis recognition in newborn, very difficult it is. And the pulse oximeters are obviously not there. The technology of pulse oximetry came later in 1990s. So after the pulse oximeter came also, it was used mainly in the ICUs. To use the pulse oximeter in resuscitation, problem was the machines were not that advanced. Motion artifact, getting the right signals in a moving vigorous baby was difficult. So those pulse oximeters which could eliminate the motion artifact and they could pick up signals in a baby in a hypoperfusion state. Mosimo achieved that, and once Mosimo came out with the pulse oximeter which can achieve this, a pulse oximeter which is dependable, reliable in a shock situation, a resuscitation situation, and then the recommendation for pulse oximeter screening or monitoring during the resuscitation came. It came first in 2010 ILCOR recommendations. SpO2 nanograms were coming. This is what we are seeing there. Fetus is hypoxic state. When you address hypoxic state, what is the fetal SpO2? 60, 50 to 60, not more than 60. From 1 minute onwards, the SpO2 increases by 5% increment, so that 90% saturation above is achieved by 10 minutes of life, which means that you need not rush into oxygen just because saturation is low. You should always understand and act only upon the saturation targets as mentioned herein. Only the saturation targets or saturation recorded is less than this target range, then you are supposed to use oxygen. That is called judicious use of oxygen. I said at any cost avoid the high FiO2. FiO2 high is defined as more than 65% oxygen. This range in bronchopulmonary dysplasia or chronic lung disease animal models it was found that anything more than 65% is toxic and induce and causes a vicious cycle where oxygen free radicals were massively generated in the site which is directly exposed to oxygen, is the lungs. Lungs are directly exposed to the oxygen you deliver, right? So from 2010 onwards, once we had this data of this preductal SpO2 of healthy infants, including preterms, and the availability of pulse oximeters, especially motion resistant pulse oximeters that can be used during resuscitation situations, ILCO recommended that you use pulse oximeter and use the target range of SpO2 to guide your oxygen therapy so that oxygen use is minimized to the extent possible. The brain behind affecting these changes, Professor Saugstad. Let's again go back and pay tribute to him now. Next. Now here, now more and more immature babies are surviving. You know that now the world is focused on surviving or understanding how to make babies in the peri-viable period. This definition of this peri-viable period has changed from 28 weeks to 24 weeks. Now people are coming down to accept or adopt 22 weeks as a viable age. Soon it might come to 20 weeks as well. So right now, these immature babies, those babies less than 28 weeks, now there are survivals of 26 weeker, 25 weeker is almost equal to what we achieved for 28 weekers about a decade before. So oxygen to immature babies in the delivery room, small babies. The philosophy here is start low and reach the target. Here it is. Start low and reach the target. Start low, reach the target. So the target SpO2 is 80% within 5 minutes. We saw it. And 90% at 10 minutes. There's a full gap of 5 minutes to achieve that final 10%. Supplemental oxygen may be needed in most immature infants. The percentage of babies requiring supplemental oxygen is higher in this extreme immature babies less than 28 weeks. And so while it is unavoidable, supplemental oxygen should, in case when it's needed, should be given at as low concentration, that is FiO2, and for as brief a duration as possible. And avoid bradycardia. Here, what is meant here? Avoid bradycardia because heart rate is the most reliable assessment marker of the response to a resuscitation. This is true in newborn resuscitation, wherein it is the lungs or the breathing which needs to be supported, and once that is taken care of, the C or the cardiac part takes care of itself. I remind you this ABC of resuscitation. In fact, it starts with TABC, thermal support, especially for extreme immature infants. You should have a polythene foil to wrap the babies to avoid heat loss or keep the baby warm. So TABC. So here C is not a priority, whereas in adults C is a priority. Here for us in extreme immature T as well as AB. So effective breathing is important, and bradycardia is often due to hypoxia. So you correct hypoxia, baby's breathing is okay. The clinical response is assessed by the increment response in the heart rate. So the combination of bradycardia and not reaching SpO2 target of 80% within 5 minutes increases the mortality. There are many studies in extreme immature infants. Bradycardia, many groups are transient bradycardia, that is less than 2 minutes, more persistent bradycardia, and those persisting more than 10 minutes, and those not reaching SpO2 target of 80%, which basically effect means that the bradycardia is in effect due to ineffective oxygenation achieved by the team. So why the titration of oxygen is needed in extremely immature babies. These are the babies who are more risk of bronchial dysplasia, chronic lung disease. These are the babies who are more risk of ROP. These are the babies who are more risk of NEC as well. So supplemental oxygen, even very brief, leads to increased oxidative stress, inflammation, genomic changes, reduced DNA repair mechanisms, and cell growth inhibition. The long-term effects by affecting epigenetic changes that is caused by oxygen-free radicals, it may also occur. So start low and titrate up according to the SpO2 and clinical response. I again reiterate here, it is the heart rate which is the response to your resuscitation. Especially heart rate reflects the effective oxygenation achieved by the resuscitation personnel. So reach target for SpO2 and heart rate, both are interlinked. Correct. So oxygen to immature babies in the delivery room, start low, reach the target. We will not expand further about the need to initiate pressure support, but this was the first 10 minutes. It is oxygen and assessment of response to oxygen by the heart rate. As to remind you, now heart rate is also not clinical in immature babies. Your babies are wrapped in polythene wrap, and you are going to assess clinically by stethoscope or pulsating pulse. Baby is so small that is often impossible or to get a correct heart rate. So what came was ECG electrodes. The ECG electrodes to be stuck on babies as soon as possible, and doing resuscitation came by ILCA recommendation 2010. That is basically to have an objective heart rate which can be recorded, documented, and acted upon. So start slow, reach the target for SpO2 and heart rate. The target SpO2 is 80% within 5 minutes. Heart rate is more than 100. Right. Next slide we go. So right now the thing is that heart rate, in spite of you having achieved oxygenation, if it is cardiac needs cardiac thing, which is the 1% of those which who require into the cardiac part of ABC, TABC, at that time the recommendation says that chest compressions are needed as and when at that point we have to increase the inspired oxygen to 100%. Make sure here, look at carefully. We start here 85%, 122 at 30% oxygen in the babies. So we need to start chest compression at some point. Means less than 100, 60. 60 is the cutoff, 60 to 100 not rising. Chest compressions, then whenever you start chest compression, it is prudent to increase the inspired oxygen to 100%. And then we have to, after resuscitation of circulation, restoration of the spontaneous circulation, then be into 21% in term baby with no lung disease, and 30 to 40% with the lung disease or preterm. Preterm baby don't mean of oxygen in total, 30%, right? How it came, you know, the professors' studies, and titrate based on the periductal SpO2. You don't stop oxygen in mostly delivery room for all preterm babies unless you're very sure babies are going to tolerate that. Once they need resuscitation, if they don't need resuscitation, it's okay, they can be in room air. But once they need resuscitation to the extent of recurring chest compression after return of spontaneous circulation, it's prudent to shift the baby on oxygen with or without CPAP support, depending upon the assessment of the resuscitation team, 30 to 40% oxygen. This is those babies who go into the C part, means chest compression requirement part. Right. So we recapitulate. Initiate resuscitation with 21% in term babies and 21 to 30% in preterm babies. Here, instead of term, now the rule has come to more than equal 35 weeks and above. We start with room air, 21%. 21% means it's the room air. Okay, 21% oxygen is present in the room air, the air we breathe. That is at the sea level. 20 to 30% oxygen is stored with all preterm babies. And look at, and then titrate the inspired oxygen based on the periductal SpO2. See, the pulse oximeter is there. There's a blunder. Need for a blunder is there, because without blunder you can't get a assessment of the FiO2 delivered. So blunder and the pulse oximeter both come together during resuscitation. So a modern resuscitation which is done in a recognized approved setting, should have a blender, should have a pulse oximeter with the motion resistant sensor and a software. So once it requires chest compression, increase the inspired oxygen to 100%, and after return of circulation, wean off to 20% quickly. In time, baby has no lung disease, but in a baby suspected lung disease or preterm baby, hold on to 30 to 40% until further assessment is done. These are all titrated based upon the preductal SpO2. Have a look at the slide here. Clear now? So O2 in the delivery room, here I said so. There is a need for a blender. It must be medical legal that if you are resuscitating in a setting without a blender, you are liable. A pulse oximeter should also be used. It's B2 evidence for the FiO2 cutoff, but it is recommended by ILCOR. So please use the SpO2 monitor. Don't forget that. Preferably ECG electrodes when you initiate chest compressions. That is also becoming mandatory. You should have this facilitate for resuscitating any approved or accredited neonatal unit. So first to 5 minutes, 10 minutes is very crucial because this is the transition to the extrauterine life. If that transition is achieved in a gentle, effective manner, that's good for the baby without invasion of intubation and further traumatizing the babies. Clear? 21 to 30% for 28 to 31 babies. More than 35 weeks, 35 and above, it is room air, 0.21. So less than 28 weeks, we say 30% is the gold standard. Now see, you are reducing the FiO2 to 21 to in between 21 to 30% for 28 to 31 weeks, but it is not still A grade evidence, it's only P2. It can be adopted later on. For present, use 30% for anyone less than 35 weeks gestation, and more than 35 weeks, simple, use room air, that is 21% FiO2. This is a B2 grading recommendation which might come for this interim babies, 28 to 31 week babies, where you can titrate or initial FiO2. Start with the 21 to 30, somewhere in between, might be 25%. We go to the next slide again. So again, you're going back. As the recommendation stands, it is just 0.21 FiO2 or 21% oxygen, that is room air, for infants more than or equal to 35 weeks, and judicious oxygen for preterm infants, that is between start with 30%, simple, and avoid always exceeding this threshold of 0.65 or 65%. 30% is simple. So remember, more than or equal to 35 weeks, 0.21 or room air. Less than 35 weeks, start with 0.3. 0.3 is important for all babies less than 28 weeks, and it's a consultant decision to use in between 21 to 30% for those babies who are between 28 to 32 or 35, right? But majority of babies, for a rule of thumb, 35 weeks and above, room air. This is initial to start with the oxygen FiO2. This is setting you should keep on the resuscitator. And those for babies, preterm babies less than 35 weeks, keep at 30%. And always have a remembrance of this target dispute range. Have a blender, have a motion resistant pulse ox in the resuscitation room. This is especially important for all accredited neonatal units to avoid medical legal issues. And from these words, I say thank you, and to please know how to use oxygen during the initial 10 minutes of life, and this is very crucial. And this is important that you document how we do resuscitation, and the proper equipment, proper way of doing resuscitation as recommended by international committee like ILCOR has to be followed. There is no exception to this. Please follow this. Is that clear? With that, I finish this presentation. Thank you very much for you all. This is Dr. Karthikeyan from Dubai on oxygen use as reiterated or presented by Prof Ola Saugstad in this sharing progress in neonatology spin 2021 held in virtually online virtual program on the 10th to the 12th of June 2021, which I had the privilege of attending from Dubai. Full version of the conference. Thank you for all.